much for joining us here. Thank you so much for joining us here today. Wow, it's an absolute pleasure for me to be moderating this session. We're going to be talking about pulmonary hypertension, and we have a real panel of experts that I know you're going to be thrilled to hear from. And I know personally, when I hear pulmonary hypertension as it pertains to a patient, it certainly is one of the things that scares me the most. So by way of introduction, I'm Beth Brady. I'm coming to you from Baltimore, Maryland. I'm a cardiac anesthesiologist at Hopkins. And we'll just go through a few things in terms of sort of setting the stage for this afternoon. So this webinar has no commercial support. We also want to make sure that you consider joining us in Seattle for next year. Seattle is a spectacular city, and I know that the meeting as well as the city will have a lot to offer. Please note that the abstract submission, that we've actually extended the deadline for submission, so please share all of your exciting work with the IARS and the team. Of note, I just learned this, that award winners will receive for those that are receiving some of the abstract awards, there's a complimentary registration and a travel stipend to the meeting that then takes place in Hawaii. So please consider submitting your research. If you missed 2023 meeting, you still have time. If you're an IARS member, you still have time to take a listen to some of the on-demand recordings, and I know that you'll find it fruitful. And then the discussion doesn't stop here today. I'm sure you are aware IARS has a very active Doc Matters community. The speakers will be a part of that, and we will certainly we will engage in conversations and Q&A live today, but also continue the discussion via Doc Matters after this session. There will be Q&A at the end. We're leaving time for at the end. So please submit your Q&A button at the taskbar to submit questions. And so now, by way of introduction, again, I am Beth Brady. I'm in Baltimore, Maryland, and I'm really thrilled to be introducing, wow, the real experts that we have in pulmonary hypertension. First, we will be hearing from Dr. Paul Heerdt, who's coming to us from New Haven, Connecticut, where he's a professor of Yale University. And I've heard him speak on this topic. He really is an expert in the field. And I've heard him speak on this topic and has a way of sort of consolidating so much of his knowledge so that it's really understandable. So I know that you're in for a treat. And thank you, Paul, for joining us here today. Next, you will be hearing from Jochen Steppan, and I know him incredibly well because not only do we share a passion for this topic, but we actually share a wall. So he's actually sitting right next door to me in our offices at Hopkins. And again, he has a spectacular way of looking at pulmonary hypertension and how to take care of really any critically ill patient for cardiac procedures as well as for non-cardiac procedures. And then Stephanie Ibekwe, I'm thrilled to introduce, and I'm thrilled that she's joining us here today from Baylor down in Texas. And she is a true clinician as it pertains to these pulmonary hypertension. So she's going to sort of take a look at least one case to sort of say, you know, how she did it, how you might do it, and then certainly we'll follow up with questions and answers. So thank you very much for joining us here today. So first, I think we'll go with Dr. Heerdt is going to be touching base with pulmonary hypertension.
Well, thank you. Let's see if we can get this to start. That come up okay?
It's not, yes, that looks great.
Great. So we're going to start with talking a little bit about the redefinition of pulmonary hypertension that's occurred in the last few years. Just a couple of things to consider. I have some financial relationships, some disclosures, none of which are directly relevant to the talk that we're going to have today. I'm also going to stop my video because the camera tends to freeze, usually with my expression in a very embarrassing way. Now, as you're probably all aware, I'm sure November was Pulmonary Hypertension Awareness Month. A common theme that came across frequently in that month is that pulmonary hypertension is a symptom. It is, why am I not advancing? Is a symptom, not a disease. And my slides don't advance. That's a problem. I'm not exactly sure how I'm going to approach this since the slides don't advance. Anybody have a seat? There we go. Let's try that. So today we're going to touch a little bit on the new definition of pulmonary hypertension. And we're going to consider this from the idea of resting mean pulmonary arterial pressure and pulmonary vascular resistance. We'll touch a bit on the idea of mixed etiology, again, that pulmonary hypertension is a symptom, not a disease. We're going to talk about it as a dynamic entity, so the difference between rest and exercise. And we'll touch a little bit on the caveats and pitfalls of interpreting absolute numbers. Let's start a little bit here where at the beginning, Werner Forssmann, who is a very controversial figure in the lower right, I put a reference here. It's fascinating to read about this guy. But in 1929, he actually did a cut down on his own antecubital vein and passed a catheter into his right heart. He then described how he walked around with it in, going up and down stairs without any discomfort. Things then took another jump in 1951 when Drysdale, having access to the right heart, now described the idea of primary pulmonary hypertension as a vasoconstrictive phenomenon. And in 1958, Wood took it even further, where he described a normal pulmonary arterial pressure as 30/15, or a mean pressure of 20 millimeters of mercury. Things took another jump in 1970 when Swan and Ganz introduced the balloon-directed catheter. Interestingly enough, despite the wealth of information that's available on the right side of the heart, early clinicians regarded it predominantly as a monitor for the left heart because of the ability to measure pulmonary arterial wedge pressure. Now, with more frequent access to the right heart and the pulmonary circulation, accumulated information was put together in a 1973 expert panel that suggested actually the pulmonary hypertension should be present when a mean pressure exceeds 25 millimeters of mercury. And importantly, in the same context, they suggested and indicated it is a dynamic phenomenon, meaning you can have normal pressures at rest that rise precipitously during exercise. The next big jump really occurred in 1998 when the World Health Organization got together and created a hierarchical etiological description of pulmonary hypertension, all based on a mean pulmonary arterial pressure greater than 25 millimeters of mercury as diagnosed by right heart catheterization. And this gave the 5 common groups of pulmonary arterial hypertension, PH, or pulmonary hypertension resulting from pulmonary venous issues, left heart disease, intrinsic lung disease, chronic thromboembolic disease, and the mixed bag of unclear mixed etiology. Now, importantly, at this time in 1998, pulmonary arterial hypertension was the combination of a mean pressure greater than 25 and a pulmonary vascular resistance greater than or equal to 3 Woods units. And importantly, something we tend to forget, we spend a lot of time talking about pulmonary arterial hypertension and other etiologies, but the truth of the matter is the vast majority of PH out there in the population actually is secondary to left heart disease. Now, things took another turn in 2018 when another world symposium got together and said, perhaps Wood was right. Maybe 25 is too high, and they reduced the definition of the cutoff for a mean PA pressure now of 20 millimeters of mercury, again diagnosed by right heart catheterization. But an even more important contribution to this was taking it just from the clinical etiological groups that were previously defined and looking at it more from a hemodynamic definition of being pre-capillary, isolated post-capillary, or combined pre- and post-capillary, and then looking at the clinical etiology groups in the context of what the underlying hemodynamic definition is. Now, keeping in mind now the mean PA pressure of 20 is the cutoff. So pre-capillary disease is a wedge pressure less than 15, whereas opposed to isolated post-capillary is a wedge pressure greater than 15. Now you notice here, though, pre-capillary has a wedge pressure greater than 2 units, not 3, with isolated post-capillary often having a pulmonary vascular resistance less than 2 units, and combined disease having an elevated wedge pressure and an elevated pulmonary vascular resistance. Now, the change in the PVR value from 3 to 2 occurred in 2022. Well, that's the dog feeder, if you hear it there on the background. 2022. based on these guidelines by the European societies. And these cutoff values were thought to better reflect the limits of normal ranges. But importantly, that was pointed out in these guidelines is they don't get translated into therapeutic recommendations. And they underscore this idea of a gray zone. What does it mean to have a mean PA pressure between 21 and 24, or a PVR between 2 and 3? And the implications of this, despite the change in the criteria, remain unknown. This is a more recent review published in 2023 that puts this redefinition into a context. And it emphasizes that the reason that there was a change from 25 to 20 is the importance of identifying patients early, because the delay of diagnosis now has epidemiologic data to demonstrate that it's linked to elevated morbidity and shortened lifespan. This 2023 review also, though, emphasized that pulmonary hypertension is a symptom, it is not a disease, and we need to consider the absolute numbers across the distribution of what the underlying etiology is. So, for example, they point out that despite the change in the definition to a mean PA pressure greater than 20 and a PVR greater than 2 for pulmonary arterial hypertension, they don't recommend pulmonary vasodilator therapy until progression of the disease, or basically the same criteria that were present of a mean pressure of 25 and a PVR greater than 3. They also emphasize the importance of exercise hemodynamics, particularly in the patients in the gray zone with that mean PA pressure between 21 and 24. This is kind of interesting. This is an interesting thing published many years ago, where they looked at normal people exercising, and they gave FiO2s indicative of sea level, 10,000 feet or 15,000 feet. And what they found is in these normal population, the cardiac output had to rise to over 10 liters a minute before the mean pressure was 20 millimeters of mercury. The idea of exercise-induced pulmonary hypertension changes the slope of this relationship. So under these settings, a mean PA pressure will be achieved with a cardiac output of roughly 7.5 millimeters of mercury. We're not able to then, this could be driven by both pre or post-capillary disease. And what we really don't know are what the implications of this exercise-induced pulmonary hypertension actually is. Now, going back to this 2023 review, they also then emphasize the importance of considering patients with interstitial lung disease, or the WHO group 2 or group 3. And they emphasize again that there's insufficient data to recommend pulmonary vasodilator in patients with group 2 pulmonary hypertension, or those secondary to left heart disease. And they emphasize the importance of having fast-track access to specialized pulmonary hypertension centers because of the different etiologies of disease. Now, the redefinitions actually underscored knowledge deficits. So after things were rearranged in the 2018 conference, the subsequent publication emphasized knowledge gaps that remain to be addressed. One of these, though, are optimizing methodologies to assess the implications of pulmonary hypertension on right ventricular function. This includes perioperative change, the idea of differences between rest and exercise, and consideration of the diverse pulmonary hypertension syndromes, or the variant etiology. This also, though, emphasized that RV afterload is more than pulmonary vascular resistance, which is our common metric, and emphasized the importance of interpreting pressure in the context of overall global function. And cited here is the fact that there is a significant number of patients that have elevated pulmonary arterial pressures, but entirely preserved cardiovascular function. The 2022 guidelines pointed out even more gaps in evidence, and I won't go through these directly, but they pointed out significant evidence gaps for group 1, group 2, group 3, and group 4. Underscoring, despite the fact of consensus ideas on what absolute pressures should be used for cutoff, there's still a great deal we don't know about the pulmonary hypertension syndromes. Now, just touching briefly on perioperative issues, we all appreciate that pulmonary hypertension imparts a perioperative risk, but these risks are not always clear. For example, pH is associated with nonspecific symptoms until advanced disease, and currently there are no early biomarkers in common use. And if we consider the idea that a definitive diagnosis depends on a right heart catheterization showing a mean PA pressure greater than 20, you have to realize that patients need to have a specific reason to be referred for a right heart catheterization. So in reality, every day in your clinical practice, you most likely take care of patients with a mean PA pressure greater than 20 millimeters of mercury. Considering that echocardiography is our most screening tool, I, like many of you, have probably seen patients that come with a diagnosis of pulmonary hypertension based on an echocardiographic exam. But as pointed out in these practice guidelines from the British Society of Echocardiography, echo is relatively imprecise. It can give you significant over and underestimation, leading to misdiagnosis and inappropriate treatment. But importantly, it underscores that echocardiography only grades the probability of pulmonary hypertension being present rather than providing a definitive diagnosis. So if we go back to what our original question is, do the experts agree about this redefinition? Well, I'm not really an expert. So what I did is I queried 7 international experts that I know and got their individual thoughts. One said, yep, I think we all agree to the point where everyone has a consensus, but the real next hurdle is going to be redefining pulmonary capillary wedge pressure. Another said, yes, there is agreement, but there needs to be a better consideration based on phenotyping. And for example, this expert said, if you look in group 1, we have idiopathic pulmonary hypertension, scleroderma pulmonary hypertension, portopulmonary hypertension. They're all linked together in one etiologic group, yet their prognosis and underlying mechanisms are distinctly different. Another said, yes, the cutoff was based really on just an imprecise opinion of a few others, and that the new cutoff is associated with data supporting prognosis. But this expert underscores, however, not every increased pressure reflects disease. Another said, yes, this is the basis of PVD-omics, and PVD-omics is a large multi-center study or trial that is going on that try to look across a broad platform, not just of hemodynamic numbers, but other components at the molecular level that can be used to phenotype patients. And this expert then says, a lot of the patients in the gray zone have normal echoes, and he prefers to exercise them. And finally, another expert said, yes, there is agreement, but you have to consider technical limitations in regard to how the absolute cutoff is defined, and for an individual patient, about zeroing the transducers, considering respiratory and heart rate variability, and the accuracy and precision of the cardiac output measurement that was used to calculate pulmonary vascular resistance. So when we come back to our original question here, do the experts agree? Well, according to this panel, yes, they do. However, every single one of them adds a however, or a but, or a caveat of something, saying that yes, the mean cutoff makes sense in terms of normal numbers, but we need to consider it in the context of individual patients. And with that, I will stop. If anybody has any follow-up questions after this is over, please feel free to send me an email. And I will give another disclosure, as I really like pulmonary artery catheters, and I'm very disappointed to see them go. And with that, I will end. Thank you.
All right. Thank you very much, Dr. Heerdt, for this great first talk. I just want to remind everybody that if you have any questions, please put them in the chat. I'm more than happy to talk about them and answer them. So I'm going to do the next step in this series of lectures. I'm going to talk a little bit more about the perioperative management, how what we just heard affects us on almost a day-to-day basis when we take care of those patients. I do not have any financial disclosures relevant to this talk. As we just heard, pulmonary hypertension is not like a single cutoff, but it's like a continuum of a disease that goes through different stages, where you have normal vasculature and no disease yet, to where you have increased uncoupling. And what basically happens, if you see an increase in mean pulmonary artery pressure depicted by the red line here, but as long as ventricular contractility is depicted by the elastance here, is able to keep up with that increase in pulmonary pressures, coupling is maintained and the patient is generally very well compensated. Stroke volume usually doesn't decrease very much, and right ventricular volume usually doesn't increase very much until this coupling breaks down. And it's oftentimes very hard to predict that. And you enter this spiral where you kind of get an increase in right ventricular wall stress, the RV starts to hypertrophy, and your septum starts to dilate and shift, and you kind of get into this spiral where it's really hard to get out of. And there's only very few medications or interventions that we have to unwind that spiral and to improve the outcomes for our patients. So we oftentimes need to be very precise in what we're doing. We've known for a while that pulmonary hypertension has impacts of positive outcomes. I know that the studies maybe over the last 20 years or so, and over the last, I would say 5 or so, we're really able to pin that down for non-cardiac surgery, with the outcomes anywhere between 3 to 5%, mostly in the 4% mortality range, 30-day mortality for patients with pulmonary hypertension. This is, of course, a very high mortality. Ideally, we want to predict which of our patients really have that high mortality, which might be better. So in an ideal model, what we take some patient factors, we'll take a surgical procedure into account, some random level of quality care, and then some very random variation, pull it in our box, pull the lever, and out pops an individual outcome. But it's been surprisingly difficult for patients with pulmonary hypertension. And though we have very new guidelines from the, not really guidelines, but a scientific statement from the American Heart Association from earlier this year on perioperative management, you'll see when we go over that, this is actually not as specific in certain ways that we want it to be. What do I mean by that? This is the algorithm they're proposing, and I'm going to walk you through that. So basically what they want us to do, first thing they want us to categorize pulmonary hypertension according to class, like one pulmonary hypertension to all the other ones. And then depending on which class you are, they want us to risk stratify this patient by a primary provider. So if you have pulmonary hypertension, you should see a pulmonologist. They did use certain calculators, and we're going to talk about those in more details in just a second. My apologies. If you have pulmonary hypertension secondary to cardiac disease, you should see a cardiologist, go through the AHA guidelines, the cardiac risk calculators, and so forth. The problem with those calculators, though, is that they're not pulmonary hypertension specific. Like some of them, or actually most of them, do not even recognize pulmonary hypertension as a risk factor. So if you go through cardiac risk certification by your cardiologist or by a pulmonologist, and they not specifically adjust the calculator arbitrarily for pulmonary hypertension, it's not captured by the calculators. And the patient should then come to an anesthesia clinic or surgical pre-evaluation, and you basically determine is the risk greater benefit, and then you either cancel or optimize the patient. So looking at the risk calculus for pulmonary arterial hypertension, there's 3 scores: the REVEAL, the Comparer, and the European Society. The 2 take-home points I want you to take away from this one is A, you wouldn't see pulmonary pressures on there or right ventricular systolic pressures. They're not part of the risk assessment. Once you rule in for pulmonary hypertension, the added benefit of knowing your right ventricular systolic pressure is 60 versus 70 versus 80 is relatively minor. And the other one is all of these risk calculators were done for predicting long-term outcomes, predicting 5-year or even 10-year outcomes in patients who are coming on an outpatient basis to their primary provider, not for the perioperative period. So what we did last year, actually a little bit over a year ago now, is we looked and see if we could use some of those mechanisms, in this case the Comparer score, and we could use that in the perioperative period. So we looked at 150 patients with PH and they were going non-cardiac surgery, and we wanted to identify some risk factors that predict their outcomes. This is our primary outcomes. As you can see, our 30-day mortality was 4.7%, which was right where it's expected to be. And our serious complication rate was relatively low with 11%, but it always depends on which ones you're counting, which one you're not. When we then looked which factors were associated with the primary outcome, there were actually quite a lot of them, and most of them were in the risk calculators. We then looked at the ones that were specific on one of the calculators, except for the hemodynamics, which we can't really do with we don't really have right heart catheterizations for all of our patients. So if you had a 6-minute walk distance that was poor, less than 440 meters, if your functional class was poor, grade 3 or 4, or we had side of heart failures as shown by a BNP more than 50 or a pro-BNP more than 300, and you underwent high-risk surgery, those were all predictors for poor outcomes. And that was very similar to what the comparison shows. If you had none of those factors, you have pretty much almost guaranteed to have a good outcome. If you have good exercise capacity, no heart failure, and were able to walk well and didn't undergo major surgery, it really didn't matter what your severity of pulmonary hypertension was otherwise, how your right ventricular pressures were, and you have almost zero mortality and very low risk of poor outcomes. So with that, we were able to especially identify low-risk patients using few and very rarely parameters. And it was, so I think the next step in what we have to do here is we have to, first of all, we have to validate that test, but for all the other risk predictors, we really have to validate them for the perioperative period. They're really good and powerful for long-term outcomes, but they're only a little bit of a crutch for perioperative outcomes, because that's not what they've been designed to do and to find out. I not say we shouldn't use them. I very much encourage everybody to use them and look at what is predictive, because it might be helpful in the period, but it's not giving us that granular definition what we like to do and predict our patient. So in the absence of that, what we do here at Hopkins is we have a dedicated person of contact for all those patients who have severe pulmonary hypertension or severe other cardiovascular disease to be evaluated and to be shepherded and optimized through. And of course, we're an academic institution, so we had to find a very long and cumbersome title for that person. And then really what we do is we do a multidisciplinary approach that is led by a cardiac anesthesia team in this case, in conjunction with our pulmonary hypertension clinic. And then we really partner with the primary teams, being the cardiologists, be it the interventional radiologists, be it the surgical team, whatever. And we really come up with a plan for those patients, which subspecialties we need, how we need to manage those patients, and importantly, how we need to optimize them and who and where they should be staffed for. So some of the risk factors that come up for poor outcomes all the time are procedure-related factors like emergency surgery, a very strong one, but not modifiable at all. High-risk surgery, similar to that. Prolonged surgery, which means more than 3 hours. And then some patient-related factors, high ASA class, concomitant vascular disease, especially right heart failure, poor hemodynamics, exercise capacity, and so forth. So in general, if you have a patient with pulmonary vascular disease, reduced exercise capacity, heart failure, and elevated right heart pressures, those are the ones that should really worry about and would benefit from preoperative optimization, which can be sometimes difficult because sometimes, or quite frequently, it's not only pulmonary arterial hypertension. It's oftentimes pulmonary arterial hypertension plus left heart disease, plus minus lung disease. It's oftentimes very difficult to tease that out. And working with our PH clinic is really helping us to do that. And while the definition requires right heart catheterization, most of our patients are only getting an echo, and very small portion get a right heart cath. But we take exercise capacity quite serious, and we actually have our patients walk quite a bit, do a 6-minute walk test, because this gives a little bit of an objective measure of the exercise capacity. Because depending how pessimistic or optimistic a patient is, they might tell you very differently what they can do or cannot do. Of course, you have to cover your bases. So if they have heart failure, hypoxia, you have to treat that, make sure they're euvolemic, make sure they're not hypoxic, make sure they have no anemia, all those little things that are good perioperative management. And then if you have to start them on pH-specific medications, again, as a minority of patients, bear in mind that this is not something you can do from one day to the other. That takes weeks to have those patients on a good regimen. And then once they're on it, they should continue them in the perioperative period. So now I'll spend the last, let's say, 5 minutes or so on the best anesthetic approach. And unfortunately, there is none. So don't worry, I'm not done yet. But what I basically want to state is that it doesn't really matter which medication you do. Really, what you have to focus on is on your hemodynamic goals. So one, of course, might be very obvious, which means maintaining coronary perfusion. Because once the RV gets ischemic, it's very hard to get it back out. So supporting right ventricular function with inotropes, especially when you're avoiding tachycardia, is beneficial. Keeping your patient euvolemic. The RV is a bit of a diva, as one of our fellows just said yesterday, doesn't tolerate hypovolemia, doesn't tolerate hypervolemia, but just needs everything to be just right. Maintaining normal sinus rhythm, I have yet to find out whether this is the wrong answer. And then decreasing afterload. And there's a bunch of things that we can do, and this is probably from the talk the most important clinical slide to take home with. All of the factors we're going to do in isolation are probably not a big deal, but the combination really makes a difference. So putting the patient on a high FiO2 to decrease the PVR, hyperventilating them a little bit, make sure they're not hypercarbic, which can be detrimental. Treating acidosis early, which can also change PVR independent of your PCO2. I know they're linked, but they also change PVR independently. Keeping them normothermic and make sure they're warm after the operation, especially if they're getting cold throughout. Ideally, And negative pressure ventilation with a spontaneously breathing patient would be preferable, but most of the time we have to put them on, frequently we have to put them on, most of the time, frequently we have to put them on positive pressure ventilation. If you do that, make sure that the airway pressure is as low as possible. And minimize drugs that directly affect PVR, like especially I'm thinking about phenylephrine with pure alpha-1 agonist activity. And then use medications that selectively decrease PVR, milrinone, INO, prostaglandins. Let's go through a case without kind of taking any of the thunder away from my next speaker here. Pre-medication, those patients can be very helpful. It does reduce stress levels. It prevents unwanted catecholamine surge. Pain anxiety is a bad thing with those patients. But bear in mind, once you give that, even low and mild hypoventilation can be detrimental, it can increase PVR, so you need to monitor them. I kind of alluded to ventilation a little bit. Anesthesia is kind of just continuum between awake, comfortable, maybe regional technique, and generally anesthesia paralyzed. In general, patients with pulmonary hypertension do well at either extreme. But once you kind of get in this middle zone, it gets murky when you have a patient with a natural airway, but a lot of sedation on board, they're not protecting the airway, they're going hypocarbic, that's when people get in trouble. So spontaneous breathing with sedation is not ideal. But if you can do it in a way that guarantees adequate ventilatory effort, that's perfectly fine. So eliminating green mask is certainly not forbidden in those patients, but should be considered very carefully, because hypocarbia is a real major concern in them. And honestly, even if you have an LMA or green mask, you still risk laryngospasm. And if you need high immediate pressure to break the laryngospasm or large anesthetic doses, both of which are very detrimental in those patients. And if you do use positive pressure ventilation, as I just said, make sure the airway pressure are low, which means low tidal volumes, long inspiratory time, and a low PEEP. Technically, you can use high tidal volumes and low rates, achieves the same thing, but it's probably not very efficient in the long run. For induction, bathroom ventilation is oftentimes a critical time, because interruptions can raise the PCO2, same with laryngoscopy when you're not FASA enough, and of course, noxious stimuli is detrimental. This comes up very frequently. Vasopressor of choice is usually vasopressin, followed by norepinephrine. It's usually the best way to get out if you're, especially in a pinch. You want to avoid dopamine if you're hypovolemic or vasodilated. And norepinephrine and dobutamine, really there's no difference between the two for cardiac index. And then lastly, anesthetic agents. Really, the presence of anesthesiologists with expertise in managing pH is probably more beneficial than any single drug that they might be using. So the different options, but really key is to prevent RV ischemia. Sometimes if I'm very concerned, I'm using a pre-induction inotrope like norepinephrine, like at low doses. And my preferred, and this is pure personal preference, is either fentanyl vapor or ketamine per vapor. And then paralyzed to improve back mask ventilation. And then you can add things to that. You can add midas, you can add dexmedetomidine infusion, especially if you do sedation case. You can use etomidate. You can use lidocaine as an adjunct. You can even use propofol, as long as you don't use a big slug of propofol followed by a volume infusion and phenylephrine, you'll probably be fine, but it's not ideal pharmacokinetics, and I'm usually not personally a big fan of it, but it can certainly be made possible. And then, as with many of our patients, using multimodal analgesic regimen, including regional technique, is very beneficial to minimize the side effect of each specific drugs. And if you find yourself in a patient with a pH crisis with pH exacerbation, you basically do everything you did before, just like quicker now. You put them on with an oxygen, you make sure they're deep enough, you optimize the RV function. That's one of the reviews we did on that one. You ensure they're perfused, make sure they're not ischemic, get them out with vasopressin, and then make sure they support contractility with norepinephrine. Actively lower the outflow with everything we said before. You might have to call for INO, you might have to call for ECMO. If you do, make sure you do it early if it's appropriate. So in summary, the incidence of patients with pH is steadily increasing, and they're at high perioperative risk. The current risk calculations we have actually are not specific for disease, unfortunately. So therefore, we really recommend a standardized team-based approach for high-risk patients, and a central point of contact, multidisciplinary team, and pre-operative optimization. If anybody wants to collaborate and help me and help us validate those risk predicting factors, I'm more than happy to make this a multi-institutional program. And lastly, right heart function is really key for management of those patients. But that's all I got for you today. If there's any questions, either contact me directly or please put anything in the chat. I'm more than happy to talk to you guys right afterwards. Thank you.
Thank you, Jochen, for that excellent presentation. And it really handholds and kind of leads us to this presentation that I'm going to give to you guys today. So I'm going to present a case, and we're going to go from the very beginning of the case until the end of the case into the ICU, and just talk about how we might approach a real world pulmonary hypertension case. I have no financial relationships or disclosures. And again, the objective of my talk is to provide concrete roadmaps for the perioperative management of patients with pulmonary hypertension. And I intend to do that by presenting you a case that we can all work through together. Okay, so we have our patient. He's a 58-year-old man with a 7-year history of lower back pain. Within the last 2 weeks, he complains of bilateral lower extremity weakness and bladder incontinence. An emergent anterior lumbar interbody fusion and vertebroplasty is posted since this patient has some spinal compromise. The patient's medical history includes a history of chronic DVTs. He's had them for years. He also has chronic thromboembolic pulmonary hypertension, which he's been dealing with for several years and is stable. He has a history of atrial fibrillation and type 2 diabetes. Current medications are warfarin, digoxin, metformin, and sildenafil, which he takes regularly and has taken recently. At the time of our exam, the patient's blood pressure is within normal limits. He's got a normal heart rate and sinus rhythm, and his oxygen saturation is 95% on room air. And our current set of labs from the emergency room shows that his CBC and BNP are all within normal limits. His INR is a little bit subtherapeutic at 1.93, and his PT is a little bit prolonged at 21.5 seconds. Pretty stable. We obtained some imaging at the time of admission. His CT spine shows an L4-S1 intervertebral bulge and spinal stenosis. A chest X-ray shows a right lower lung consolidation, which is concerning for pneumonia, although the patient is not symptomatic, and an enlarged cardiac silhouette. The TTE that was done in the emergency room shows a dilated right atrium, right ventricle, and left atrium. He's got moderate tricuspid regurgitation. APSP is noted to be 103 millimeters of mercury. His RV systolic function is mildly reduced with a TAPSE of 1.5 centimeters. He's got intraventricular septal flattening and diastole. No thrombus is noted in the PA, and he's got mild MR and an EDA ratio of 0.8 and an EF of 50%. So before we get started, I want us to all kind of consider a few questions. What are your top 3 concerns with this patient? Just kind of think through that as we're going through. What monitors might you use for his intra-op course? What medications would you insist on having prior to the start of the case? And what is your postoperative plan for this patient? I'll give you a minute to consider those questions. So let's talk a little bit about perioperative planning. Our perioperative planning might include adequate perioperative evaluation. We might want to start thinking about our anesthetic carefully and start planning it. A strategic use of our pH target therapies, including what he's been taking at home, as well as our intra-op and postoperative plans, and a multidisciplinary team coordination. Some foundational questions that we might pose ourselves, similar to what I've already asked you, is what is the etiology of the pH of his pulmonary hypertension? What is a patient's functional status relative to the planned procedure? And are there modifiable risk factors within the surgical time frame? As we think about our specific patient, we think about the etiology, and just as Dr. Heerdt talked about earlier, we know that he's got group 4 disease, right? He's got predominantly chronic thromboembolic pulmonary hypertension. Unfortunately, we're unable to assess his functional status since he's had this lower extremity weakness, but prior to 2 weeks ago, he states that he was in his normal state of health. And in terms of modifiable risk factors, as Dr. Steppan mentioned, most of the things that we're going to do to modify the disease will take several weeks. In his case, this is an emergent case, so we don't have really a lot of time to modify things. We do have some time to optimize, and we'll talk about that. But since it's an emergent case, we're going to kind of move forward, unable to complete that step. Let's talk about the perioperative predictors of morbidity and mortality. And Jochen was able to give you kind of some information about that, and we'll kind of go a little bit deeper. So on clinical assessment, if you have a patient who's presenting and you're thinking, okay, they've got a history of pulmonary hypertension, how do I know whether or not they're going to have, a higher risk for poor outcome perioperatively? A rapid progression of symptoms, including syncope, chest pain, arrhythmia, and shortness of breath, might give you an idea that on clinical assessment, this patient's high risk. If on your clinical exam, the patient has some evidence of right heart failure, peripheral edema that's new, and things like that, that might be something that clues you, and a functional class of greater than 3 or 4. On imaging and hemodynamics, echocardiographical evidence of right ventricular dysfunction, so your fractional area change or your TAPSE being abnormal, and also presence of pericardial effusion clues you in. On CMR, right ventricular EF of less than 37% is indicative of right ventricular failure and increasing morbidity and mortality risk. And also right heart catheterization numbers, such as the right atrial pressure greater than 15, a mixed venous saturation of less than 60%, or cardiac index of less than 2 liters per minute per meter squared. Of course, we also want to talk about the mean pulmonary artery pressure, which we talked about before, being greater than 20. On exercise testing, a 6-minute walk test of less than 399 meters should clue you in. And some biomarkers that we could also look at, such as BNP and pro-BNP. Perioperative changes that increase our pulmonary vascular resistance include hypoxia and hypercapnia, things that increase your pulmonary vascular resistance. So due to sedation, analgesia, inadequate mask ventilation, or delayed intubation, and even on extubation, laryngospasm, these things increase hypoxia and hypercapnia. So this is a perioperative change that can increase your risk for pulmonary vascular disease and pulmonary crisis. Acidosis secondary to hypovolemia, infection, decreased cardiac output, hypoventilation. These are all things that can increase your risk. Hypothermia caused by cold IV fluids or ambient temperatures. Atelectasis and hyperinflation, too large of a tidal volume, too much PEEP, or even too little can cause an issue. Catecholamine release, such as pain, inadequate anesthesia, and anxiety. Say you have a patient who's having procedure and you're attempting to do the case with as little as anesthetic as possible. You're actually not helping the patient in doing that, right? Because now they're having pain and anxiety associated with the surgical procedure, and that's increasing their pulmonary vascular resistance. And medications such as pure alpha agonists, which Jochen kind of briefly mentioned in the last lecture, giving your patient a large slug of propofol and then following it with a IV infusion of phenylephrine is not the best approach for these patients. And similar to the 3 little bears, you just don't want too little or too much of anything when it comes to these patients. You just want it to be just right. And so we'll try and work through that with our patient. So our anesthetic planning in the preoperative area, we noted that this was an emergent case. So a formal multidisciplinary team was not possible, but we did meet briefly with our surgical, critical care, cardiology, and cardiovascular surgery teams to discuss our perioperative goals, our postoperative disposition, which we plan to take the patient to the ICU for 48 to 72 hours postoperatively for good monitoring of the patient. And we discussed whether or not ECMO would be available for this patient. And in our case, it was not available, but that's something that you want to have an understanding of as soon in the perioperative phase as you can. You want to review the preoperative testing results and repeat pertinent testing if needed. So we talked about the TTE findings on the patient's admission, and we also went back and found the right heart catheter from 3 months prior, which showed that his right atrial pressures at that time were 12 millimeters of mercury. His index was 2. He had a mean PAP of 80, which was elevated, but a functional class of 2. So we felt that the patient, although not perfect, was at about his baseline in terms of his health. We ensured that our pulmonary arterial hypertension medications were available. In our case, we went ahead with some inhaled nitric oxide. And then we also made sure that the patient had received his home dose of sildenafil prior to the procedure. And then we wanted to ensure that our inotropes and vasopressors were available. Inotropes, we're thinking milrinone or dobutamine, beta-1 agonist. And in terms of vasopressors, like we mentioned before, vasopressin being our first drug of choice and norepinephrine our second. And then we wanted to just ensure that the patient had good peripheral access for the administration of all of our medications prior to the case start. Intraoperatively, we opted for standard ASA monitors. We also made sure we had a pre-induction arterial line on our patient. We have the ability to do ST segment analysis, so we went ahead and had that going prior to the start of the case and prior to induction. We also obtained CVC so that we can monitor the patient's CVP throughout the case as part of our monitoring of the right heart and its pressures. We also went ahead and got a transesophageal echo probe placed on our patient and some advanced hemodynamic monitoring for continuous cardiac output and cardiac index tracing. Our induction goals were for us to have a balanced induction. We wanted to blunt the sympathetic stimulation to laryngoscopy with fentanyl and lidocaine, but avoid myocardial depression and large swings in SVR. And so but in order to do that in a balanced way, we opted to do a slow induction with continuous bag mask ventilation, carefully conducting laryngoscopy, and having minimal hypoxemia time. And so we use a video laryngoscopy for this patient. We also use etomidate just as a aside for this patient, but that's not necessary as long as you're going slow and keeping your hemodynamic goals in mind. For maintenance, our goals were to avoid high airway pressures, and the method to do that is to do an RV protective ventilation strategy with low tidal volumes, low PEEP, and low plateau pressures. We also intended to maintain our coronary perfusion and SVR by utilizing norepinephrine and vasopressin infusions and beta-1 agonists as needed for inotropic support, keeping in mind to avoid tachyarrhythmias, especially in our patient who had a history of atrial fibrillation. Our post-op plan was to monitor the patient in the ICU and continue his medications as soon as possible in the ICU. And if we had increasing inotropic and pressure requirements, we were planning to repeat TTE to assess the right heart function, and with high consideration for repeating any type of right heart catheterization testing. We didn't run into pulmonary hypertension crisis during our case, but just as an aside to try and talk about what you would do if you ran into it, the first thing is you want to recognize it, right? So our patient who's having increasing PVR and RV filling pressures or increasing CVP with decreasing cardiac output and blood pressure, this is a patient who is at risk for pulmonary hypertension and at risk for precipitating cardiovascular collapse. And the next thing you want to do is treat as early as possible. So aggressively treating hypotension to avoid RV ischemia while continuing your pulmonary vasodilators, your afterload reducers is very important, and reducing PVR with inhaled and IV pulmonary vasodilators, improving RV function by optimizing your preload and contractility, being careful about your fluid administration, and kind of making sure the patient's euvolemic. If your patient's hypervolemic, administering a gentle diuresis, and administering fluids if your patient is hypovolemic from bleeding and other things in the case. And then again, inotropic support with milrinone and dobutamine for our treatments of choice. And again, you know, if you have ECMO available at your institution, that would be the next step in the patient who's in fulminant RV failure and unable to be righted with your medication administration. So let's revisit the questions that we talked about at the very beginning of the case. What are your top 3 concerns now, as you know, that we've talked through the last 3 lectures? How do you approach these patients now? Has that changed? You know, just kind of think about that. What monitors would you use if you had a patient similar to the one that I presented before? In most cases, it's not necessarily needed to place a central venous catheter, but in our patient, it proved to be very helpful. What medications would you insist on having prior to the start of the case, and what is your postoperative plan? Let's revisit our patient from earlier in the day. So our patient's hospital course, he had transient hypotension and bradycardia with an elevated CVP during implantation of the vertebroplasty cement, likely a reaction from cement placement. We noticed that early and started a dobutamine infusion at a low dose with improved heart rate and blood pressure. We also performed a TEE and noted that the right ventricle had a TAPSE of 1.5 centimeters, which was at his baseline. Over the next 30 minutes, the CVP trended back to baseline values, which was definitely headed in the right direction. No other significant hemodynamic changes were noted during the case, and he was extubated and taken to the ICU. Postoperatively, he was restarted on his home regimen of sildenafil on post-op day 1, along with his other medications, save the warfarin, which we waited until his bleeding was controlled. And then he continued to be hemodynamically stable and off all pressors thereafter. He was discharged from the ICU after 48 hours and went on to have a good rest of his stay. Here are my references for your continued reading. And I just want to say thank you for including me in this awesome webinar. It's been really great. And here's my email address if you'd like to continue this conversation afterward. Thank you.
Okay, great. Thank you. Gosh, thank you so much to the experts for your time and expertise. You know, these patients really always scare me, and these are the patients I get so many questions about. And I want to thank the audience because it's been a very engaged audience. We have lots of questions. And I will say before, if we don't get to all of your questions, please know that I think every speaker has left their email address. Additionally, the IARS will keep a list of the questions. And if your contact information is in the question, then the speakers will reply to you directly. And then certainly the conversation can continue on in terms of doc matters. So I think we'll just get started and sort of go down the list. One of the questions has to do with the majority of patients that we see in terms of anesthesia are probably type 2, where the LV failure is the issue. And so maybe, Paul, if you wanted to address, you know, when we're taking care of these patients, should we focus on pulmonary hypertension or should we focus on sort of the LV failure component of it?
Yeah, I think the primary indication there is the left heart dysfunction. It's a plumbing issue. So if you begin to have a rise in LV filling pressures, it's going to be transmitted across the circulation. The complicated group there are those that have combined disease, which we're beginning to appreciate is a little bit more common. So they don't just have purely left heart elevated pulmonary venous pressures. They also have a remodeling with a component of the pulmonary the pulmonary arteries themselves. So I think broadly in the question, the predominant thing is to address the LV dysfunction. If you've got severe mitral regurgitation, you're going to have to unload the left ventricle to lessen the MR, for example. So I think the primary indication there is treating the left ventricle, which then should have implications for the right side. And the variability of that response is going to depend on how much pulmonary vascular remodeling they have to combine both left heart and pulmonary circulation abnormalities.
Okay, great. And then Stephanie, there was a question about ASA classification, and you know, in your thought process, do you consider anyone who has sort of pulmonary or this arterial hypertension to be a ASA class 3? And then Jochen, if you wanted to comment on, you know, as you're sort of you know, recommending who might take care of these patients, do you put a lot of emphasis on the actual ASA classification? So Stephanie, for most of these patients, would you consider them ASA class 3?
You know, just honestly, probably they would be an ASA class 3, but I also take every patient kind of at a patient-to-patient basis. And so if you have a patient who has a long-standing history of pulmonary hypertension, but they've got good functional status, they're well controlled on medications, that patient may not be an ASA class 3, which is the disease process of the constant threat to life. In that case, that patient's well controlled and could be an ASA class 2. But it really is a patient-to-patient basis. You know, they may end up being more ASA class 3s, but I wouldn't necessarily do a blanket term like that.
And then Jochen, do you put much emphasis on the ASA classification as you're sort of with the program that you have in terms of taking care of these sick patients?
I mean, the ASA classification is one out of many parameters that we use to risk stratify those patients, and none of the parameters we have or indices in isolation are going to be very predictive. We do put the ASA classification in account, but honestly only for, as Stephanie mentioned, the patients who are doing well. Because if a patient is ASA class 2, if they have good exercise capacity, if they have normal right ventricular function, they do have pulmonary hypertension, but they might be in the early stages, then it all comes together and it just ended up being an ASA2 because of that. And then we certainly take this into account. But none of the parameters we have in isolation is going to be very predictive. It has to be a joint effort of multiple parameters.
And then Dr. Heerdt, there was a question about right heart cath. Is there any circumstances where you worry that the diagnosis is inaccurate? And then I'd also, just on a personal level, echo is one of my things that I totally enjoy. When it sounds like can you comment on how you might interpret some of the echo findings that you show? In other words, it sounds like very often we're inaccurate in terms of sort of as we're evaluating these patients. So maybe first in terms of the right heart cath, is there any time where the diagnosis might be inaccurate?
Yeah, it's interesting. And in fact, this just came on my radar even more recently because I have a huge data set of right heart caths that we've been looking at. And the answer there is yes, for two reasons. One is the imprecision of the interpretation of the pulmonary pressure. I've seen several of these where there's artifact associated with it, and the artifact is being read into the pressure. I've seen ones that were completely misread. So I just saw one the other day where the recorded wedge pressure was higher than the mean pulmonary arterial pressure, which means they had a negative pulmonary vascular resistance. And this was recorded in the patient's chart. So that's clearly an abnormality there and would have underestimated the severity of disease if PVR became a component of it. So I think the question there is, yes, it has to look, and then you got to get respiratory variation and a variety of things, particularly when we get into this gray zone. If it's severely high, it's severely high. But I think some of the subtleties go in so I think that and how cardiac output is measured. We often, if the cath often use indirect FIC has all kinds of problems with it. And thermal dilution has its own problems in the setting of tricuspid regurgitation. So if we're using those metrics for calculating PVR for severity of disease, they can also impart an error. So I think that's, and then in terms of echo, it's really kind of fascinating. The literature and our data also in our big data set show that echo is relatively accurate for predicting PA systolic pressure, but it's profoundly imprecise. So there's a value there for getting some idea that the pressure is elevated, but the magnitude of elevation, it becomes where the problem is. And then classically diagnosis is done on mean pressure, and the echo methodologies for estimating mean pressure are there, but they're not particularly good. So yes, as a screening metric, it's good. As an acute change in an individual, it's good. If you're able to get a TR window that's useful, which in my practice, is maybe only 75% of the time. So yeah, there's a utility there, but an absolute definition metric, echo still hasn't met the mark.
Okay. Stephanie, can you comment? There was a question on what is your take on regional anesthesia, specifically sort of epidural and spinal anesthesia? Does that increase or tell me what you think about that in terms of risk of these patients?
Sure. Just like giving the patient propofol, right? Our epidural and spinal anesthetics are going to reduce our SVR. And so whenever you want to do either one of those techniques, you want to make sure that you're able to monitor your patient closely, whether that's placing an arterial line, doing non-invasive blood pressure cycles quickly, or more often than you would a patient who is a typical patient coming for an epidural or spinal. And then lastly, whenever you're dosing up your medications, you want to do so in a controlled fashion. You don't want an abrupt reduction in your SVR. And so giving the patient a high dose of local anesthetic in the spinal, likely not a good approach, especially if you haven't preloaded them with volume, given them some type of vasopressor that might help to reduce the reduction in SVR in that way. You just have to approach these patients a little bit more strategically with the patients with pulmonary hypertension, always taking in mind their disease process and how severe their pulmonary hypertension is.
And then Jochen, one of the audience members was considering or how they like to do the case is to put an LMA in as opposed to sort of the monitored anesthesia care for certainly for low or intermediate risk patients. And I think you had that chart that showed sort of general anesthesia, or I think it was sort of near awake, and in that middle zone can be sort of challenging. So maybe could you comment on sort of the use of LMA versus MAC?
Sure. I think as you just alluded to with that chart, as close you are to like awake and having adequate ventilation, but it's just a straight regional technique and maybe some electrolysis is ideal. But oftentimes we just need a little bit more than that, and then it becomes murky. I think having an LMA for those patients and actually getting a good indicator of how well they're breathing, and especially using some positive pressure in the LMA and you're helping them to breathe, I think is really beneficial. If you only have the LMA in there and you have them spontaneously breathing, I don't think you get much benefit. But if you support the patient through it and actually get the vent down a little bit, I think it can be a very nice technique.
Okay. And we are coming on to the hour, so we still have tons of questions. So again, the conversation will continue on with Doc Matters, and then we will also, the speakers will make every attempt to answer any of your questions that are listed. And I just want to really thank everybody, our speakers, but most definitely sort of our IARS audience for joining us here today. I really learned a lot. Thank you, guys.
Thanks a lot for attending.
Thank
Thank you
you.
to the IARS for having us.